Our next person up for bids is another DEFCon veteran, and a long-standing friend of ours. And he is coming to us now in almost a new era in Cuban-American relations, and that is Jorge Berlanga Acosta. And Jorge has been a long-time member of the Center for Bioengineering and Genetics in Cuba. He's done a great deal of work in wound healing, published widely on the subject, and now I think much of his good works are being heard on broader stages for a lot of really good reasons. Will you please help me welcome Jorge Berlanga Acosta, who's going to speak on Diabetic Foot Detente, where we see a Cuban-American digital alliance. Dr. Acosta.
Thank you very much. Good morning, ladies and gentlemen. For me, it's a great pleasure. It's a sort of a dream come true to be back here. And my special gratitude for Professor Armstrong for his efforts. It has given me the opportunity to bring some information of what we are doing in my country and to shake hands with worldwide leaders as Professor Armstrong, Professor Mandrums, and Professor Bolton. So going to the first slide, I think that after this paper in International Wound Journal quite a few years ago, there is nothing left to say. And Dr. Armstrong has clearly demonstrated that amputee patients, diabetic amputee patients, have a poor survival rather than 3 forms of aggressive cancer. This is a very heart-touching message in which we still have to work a lot. Therefore, survival is a serious challenge for our patients. So amputation, if we look at the roots of amputation, we see that there are 2 major forces which pave the way toward this difficult and sad outcome. The first of all, and there is a lot of information in papers, is about the failure of the diabetic patients to recognize and to present antigens, or what is called the danger signals. So the innate immunity, at least in periphery, is demised in our patient. In combination with this propensity to infection, it is on the other hand the propensity of unchronification. And the point is that because diabetes erases from the mind of the cell the most primitive instinct to repair the damage. So if you combine infection, which is, of course, very aggressive in diabetic patients, with the other, the open door, the long-lasting open door, of course, the more infection, or the more open door, the more infection, and there is a sort of conspiracy and evil marriage, which afterwards leads to amputation. So if you ask me why diabetic patients always chronify the wounds, I for sure will reply that I will answer that there is no single cause for which the diabetic patients chronificates the wounds. So there are very many pathways by which the wounds can go to onset of this phenotype. But the point is that diabetes depletes the cell from reserve, which are innate, which are imprinted on the brain of the cell, on the core of the cell, in order to repair the damages. So here I have tried to compact, which is the most recent streamlines on research on the onset of the chronic phenotype in diabetic patients. Of course, always glucose toxicity is the primary player on this stage. And from glucose, of course, is the accumulation of advanced glycation end products, the upregulation of the receptor for these advanced glycation end products, and inflammation. This triad seems to be the most important basis, the foundations of all the process of complications that we have in diabetes. And from these, everything is triggered and leads to the point of non-return in terms of molecular events, which lead to the complication, especially to the chronification of the wounds. Something which is extremely important and has been recently identified is that we have a sort of constitutive basal activity on tyrosine kinases and the release of growth factors. And growth factors has a sort of a constant pull in autocrine paracrine activity. And the growth factors, I'd like to remind you, that are the commanders of the regenerative process in our body. So whether stem cells or non-stem cells are commanded by growth factors. And in diabetes, there is a reduction of growth factors and the activity of the receptor of the growth factor. So I also like to remind you that diabetes is a very toxic disease with the overproduction and spillover of radicals, free radicals, oxygen-free radicals, especially because of the damage of the mitochondrial DNA. And this mitochondrial DNA, once it's affected, of course, there is a full failure, a complete failure of oxidative phosphorylation, and there is a larger spillover of free radicals. All of these elements mean glucose and free radicals bind incredible, believe it or not, are able to transform the epigenome of the cell. And that is what I call the wizardry of diabetes. Since 20 years ago, it was introduced the concept that diabetic is something wizardry, because there is probably the only disease in which there is a memory. Unfortunately, the animations are not working, but what I'm trying to show you here is how the advanced glycation end products are able to bind to lysine and histidine residues of histones. And once they are bound to the histone, there is a complete change. There is a sort of a transformation of the epigenomic memory of the cell. So, and once you have transformed the landscape of the epigenome, the cells, of course, erase the natural and physiological instincts of repair. And only through the concept of metabolic memory, we can explain a number of findings that we have been obtaining in our group since about 2 or 3 years ago. And the point is, unfortunately, I have no time to go into details, but the point is that we demonstrated a year ago that granulation tissue in diabetic patients behaves like, at least from the transcriptional point of view, behaves like an insulin-resistant organ. And if you look at the origin of what's granulation tissue, it's a simple, a short-lived organ in order to heal the wound, in order to fill the gap. It's a transient organ that is afterwards replaced by collagen scar. However, from wherever come the cells, the fibroblasts or the fibrocytes or the myofibroblasts that make up the granulation tissue, this granulation tissue has the genomic imprinting, which is similar to the liver, to the fat tissue, and to the skeletal muscle in individuals with insulin resistance or type 2 diabetes. So this is very exciting. And if you look at these slides, which are purely results from our anatomical pathology lab and published recently in a paper in collaboration with Professor Armstrong, what you see here is what I'm trying to show you, is that the diabetic memory or the glucose legacy is able to disrupt the natural morphogenetic processes in our structures. What you're seeing here is a fragment of granulation tissue in which 10 days granulation tissue exhibit the engorgement or the thickness of the wall of the vessel. So think about that the atherosclerosis or the media thickening takes years to be onset in diabetic patients. However, the granulation tissue of the wound in short time, I mean just in days, can replicate a process which has taken years. And this is, at least for me, is really thrilling, is really exciting. And on the other hand, on the on the right is what I'm trying to say, is that the vascular wall of diabetic patient in granulation tissue is a plant manufacturing pro-inflammatory cytokines, which is absolutely pathological or absolutely abnormal, of course. This is the wizardry of diabetes, is what I'm trying to highlight. And we must think about a day in which we could reprogram the diabetic cells in order to restore or in order to reverse the complications which have been onset by the disease. One of the translations in the clinical point of view when we deal with the wound of the diabetic patient is the angiogenic failure. And what I'm trying to show here is the decrease in vascular endothelial growth factor, hypoxia-inducible factor, and nitric oxide synthase, which are the three major pillars which are in deficit in the wounds of the diabetic patients. The other failure we have, and is really a headache for the clinician, for the patient, and for the researcher like me, is the failure of epithelialization. To my understanding, the most complete paper published was in the group by Olivera Stojanovic and Marjana Tomikanik in Miami Miller School of Medicine in American Journal of Pathology, in which they demonstrate that in diabetes, the epithelial cell, the keratinocytes, lose the polarity or lose the sense of migration, and instead of migrating and covering the wound, they migrate downward. And this is a serious complication, because sometimes we have a granulation on the wound, but still has not been epithelialized. The other is the contractile failure. Unfortunately, I think the animation is not working anymore, but contraction is very important because contraction reduces the 30 to 40% of the wound area. So the metabolic effort of the epithelial cells is less, of course. Contraction is absolutely blunted by diabetes by a number of molecular mechanisms, which I have no time to go into details. Why the EGF for diabetic wounds here is what I'm trying to address to you, our story, the Cuban approach to deal with diabetic wounds. Don't forget I told you that growth factors are reduced in diabetic patients, and therefore whatever we do in terms of replacing the growth factors is important for the physiology of the cell and perhaps for the future resetting of the metabolic memory of the cells and the epigenome of the cell. And EGF is one of the most reduced growth factors, as I'm showing here by different preclinical and clinical studies. And if you ask me why EGF specifically, I can tell you for sure that two major effects of EGF. First of all, EGF is a very potent cytoprotective growth factor. And don't forget, diabetic cells are intoxicated by free radicals, and the advanced glycation in process is intoxicated by cytokines and the excessive exposure to chemokines. And the other point is that, of course, EGF is able to restore, to enhance proliferation, to enhance secretion, to enhance migration, but not recruit inflammatory cells, which is a drawback we have in other growth factors like PDGF or TGF-beta1 or CTGF. And therefore, what we are doing here by injecting EGF into the wound is a replacement therapy. So we are incorporating to the wound what diabetes took away from the patient. And we have a lot of basic science behind to propose that infiltration of the wounds in terms of the injected into the contours of the wound and the bottom of the wound is based in a lot of basic science that we have done many years ago. Well, I have no time to explain, but the point is that injection is the right procedure to put the growth factor, wherever it is, whoever is the growth factor, into the responsive cell, which still express their receptors. And this rationale for infiltration is summarized here. We prevent degradation, we avoid the physical barrier of the biofilm, and we touch the cells which are committed to respond and to proliferate and secrete and contract the wound. This is roughly the basic science what we have in behind. Here I'm showing you what was the first clinical trial many years ago, 14 years ago. This is the paper. 29 patients from 2917 were rescued from amputation. I'm talking about Wagner grade 3 and 4. Afterwards, we have progress. We have registration in 23 countries, patent granted here in the United States, European Union, and we are going through the marketing, post-marketing surveillance, and we have gone through 3 impact studies in terms of reduction of amputation. All have been published in peer-reviewed PubMed index of the journals, and the point is that we have 3 major effects. One is reduction of amputation in a limited number of studies, of course. We have a prolonged survival of the patients which heal, and the other is we have a very impressive reduction of recurrence. Of course, this is based, and the success of this program is based on the creation of a national team, a national staff who look after the diabetic patients in the primary health system, and this is very important. Otherwise, we do know nothing. I can tell you that along these 14 years in which the therapy has been progressing, I can tell you that we have almost 170,000 patients treated in Cuba and around the world. We have the medication in 15 countries, and there are Cuban specialists working with these national physicians, and we can deal with stages 2, 3, and 4 of the Wagner classification, and we are extremely delighted to offer this procedure and to show this procedure to you, because certainly we have reduced in our country, in Venezuela, Ecuador, and South Africa, about 70% of the rates of amputation with this procedure. In the 4 minutes I'm going to show you this slide. Perhaps if you show me this picture, last year when I was here standing in this podium, I wouldn't believe it, but this is true. Our both presidents announced on September 17 at the same time in Cuba and the United States that our country were decided to resume our relationship after 55 years of misunderstanding. And as you can see here, Mr. Obama is smelling a Cuban cigar. So I think this is a good opportunity that we have, especially myself, who is a devote of the work that has been conducted in salsa. Listen up, listen.
You gotta learn to play it right. You got to know when to hold up, know when to fold up.
This is a nice picture with a nice American song, Professor Armstrong and Professor Joe Mills. And my hopes, and our hopes from my institution, is that we sooner than later, we have here our medication Heberprot to treat U.S. patients, and that we have a lot to share in terms of basic science, working on the unraveling, on the scoring the basis of chronification and metabolic memory in order to improve the health of our countries, our patients, of course. And of course, we can conclude that Heberprot infiltration is suitable to treat the complicated diabetic foot ulcers, those ulcers which have a poor prognosis, because we reach the layers of cells which express the receptors and express the switches to enhance cell proliferation, that EGF as a growth factor is self-sufficient to enhance the process of wound healing and to sustain the process of wound healing, that Heberprot intervention is efficacious, is safe, and obviously is the answer of the title of my talk recommended by Professor Armstrong. Will we see a Cuban-American alliance? Yes. I think that we will have a Cuban-American alliance with Salsa Institution in order to enhance the welfare of our patients. So I want to thank you very much. And my humble conviction is that perhaps with the Heberprot has helped to heal very many complicated diabetic foot wounds, and perhaps somehow Heberprot will help to heal the wounds between our two countries. And thank you very much for your attention. I'm a basic scientist. I'm a basic scientist with some background in pathology. I don't know if I succeeded in translating the basic science into a more Christian speech, but I think I've done my effort. I thank you. Thank you very much.